Hi, everyone. Thank you for joining us today. This is being put on by the Pasco County Substance Exposed Newborn Task Force. We wanted to get together to talk to some great panelists about substance exposed newborns and pregnant mothers with substance use disorder. We are hoping to create a better system of care for these moms and babies. So again, thank you all for being here with us today. Feel free to use the chat feature for any questions that you might have. We will address them at the end if there is time. And I will start with doing some bios for our panelists. All right,
Hi, everyone. It's Dr. Fields.
Good morning.
Good morning. I just got to join. Sorry about that.
That's all right. Thank you for joining us. I was just welcoming everyone, and I'm going to share some of the bios for our panelists. All right, so Dr. Fields is currently practicing addiction medicine with Baycare Behavioral Health. He joined Baycare over 3 years ago and has incorporated best practice medication-assisted treatment, and outpatient addiction medicine into their behavioral health practices. Dr. Fields was a pediatrician in his early career and beginning about 2011, made a transition to behavioral health. His fellowship in addiction medicine was done with the University of Florida, and he was medical director of DACO, now Cove Behavioral Health, and associate medical director of Advanced Recovery Systems before joining Baycare. He is a distinguished fellow with the American Society of Addiction Medicine and is board certified in addiction medicine through the American Board of Preventative Medicine. Dr. Fields has a special interest in treating pregnant women with substance use disorders and has done many presentations and expert panels on the subject. He is past president of the Florida Society of Addiction Medicine and is currently their treasurer. Ellie Farrow graduated from, I might say this wrong, OLU, Our Lady of the Lake University in San Antonio, Texas, with a master's in social work. She has been with Baycare for over 20 years and has primarily been assigned to labor and delivery units. She currently supervises and manages the Healthy Families Grant. Ellie has 2 children who she is very proud of. Shalise Lusk has been focused working in the child welfare arena since 2008. Shalise has firsthand experience working as a case manager in this community. Since that time, she has gone on to continue to support the child welfare communities in Hillsborough, Pinellas, and Pasco counties in various leadership roles, including quality assurance, out-of-home care, licensing, and most recently as Director of Judicial Case Management with FSS. Shalise is also a mom of 2 and previously a non-relative caregiver. Angela Santiago is currently with Safe at Home Pasco. She received a bachelor's degree in psychology from the University of South Florida in 2010 and a child welfare case management certification with USF in 2020. She has been a certified child welfare case manager for Gulf Coast JFCS Safe at Home Diversion Program since August 2020. Before child welfare, Angela worked for the Tampa Bay Rays as a certified yoga teacher and wellness coach from 2011 to 2020. Angela has 4 children of her own, ranging from ages 3 through 13. Jenna Thompson is the supervisor of Healthy Families Florida captive team and is a nurse. Her area of expertise is education and mental health and substance use. She has been with Healthy Families for about 1.5 years. She is also a mom, and that's currently her biggest focus. Jenna is passionate about removing stigmas related to mental health and making sure that everyone has access to proper health care and education. Heather Land has a master's degree in developmental disabilities and is currently employed as a trainer with the Pasco County Sheriff's Office. She has been working as a child protective investigator for the past 7 years and has a total of 9 years working within the field of child welfare. Michael Osborne is currently the clinical director of operations for the PAR Medication Assisted Patient Services Program, also known as MAPS. He begins his career at Operation PAR in 2009 as a substance abuse counselor. He has 13 years of work experience with substance use disorder clients and has obtained state and national credentials of LMHC, MCAP, and is nationally certified counselor. Michael's objective when working with persons diagnosed with substance use disorders is to teach coping skills, collaborate and develop specific and attainable goals, give them insight into their addiction, and create an atmosphere conducive to change and offer them hope for a healthier life. Cindy Cook is the program manager for the Healthy Start program at the Florida Department of Health in Pasco County. She's worked for Healthy Start since 1999, 23 rewarding years serving moms, babies, and families. Prior to working for Healthy Start, she worked for vocational rehabilitation in North Carolina. Her caseload included incarcerated males or males on probation with charges primarily including substance misuse. She also worked for the Mary Frances Center in North Carolina and the first drug and alcohol treatment center for incarcerated females in the state of North Carolina as their community liaison for the center, which has recently closed. So those are some pretty impressive bios. Thank you all so much for being here with us today. We will go ahead and get started with the panelists' questions. Once again, just as a reminder, please keep all questions in the chat. Please keep yourself on mute. We will address questions at the end if there is time. All right, so our first question is for Dr. Fields. What are the most prevalent substances you see mothers using during pregnancy? And do these differ from substances being used by women of childbearing age in general?
So, hi everyone. Thanks for letting me be part of this panel today. And yeah, so I have in my 11, 12-year career with substance use treatment encountered, we've been in the wake of an opioid crisis. So what I primarily treat when it comes to addiction treatment in substance using pregnant women is opiate use disorder. So in this crisis, it's the opiate itself that I've primarily seen being used has changed over the years. Initially, in the early 2000s and even later 2000s, it was primarily prescription opioids. And then the opioid crisis has gone in certain waves with the start of the prescription drug monitoring program and the Department of Health imposing new guidelines on so-called pill mills. A lot of the dispensing, unregulated dispensing of prescription opioids changed. And so pregnant women, along with all populations who were abusing opiates, shifted to heroin. And then unfortunately, in the last 4 or 5 years, we have seen a rise and continue to rise use of synthetic opioids, primarily fentanyl and fentanyl analogs in this population. So pregnant women have mirrored the population in general and continue to, we unfortunately continue to see a lot of women of childbearing age get pregnant while active in an addiction with opiate use disorder. Opiate use disorder is commonly, there's other substances being used, not just opioids. And so the number 2 epidemic nationwide, and this is reflected in substance using pregnant women population, is stimulants. And we're seeing more methamphetamine, unfortunately, which actually is the most detrimental substance to use. Methamphetamine, single use, can be very, have poor outcomes during a pregnancy, especially continued use. So I'm seeing that combination of stimulant use disorder, primarily methamphetamine, with opiate use disorder in the population. We always have had to address also alcohol use disorder. I think that in my experience, what I most commonly see is the opiates and the methamphetamine and cannabis also. Cannabis is something also widely abused, as well as nicotine. Alcohol here and there. I've had a substance using pregnant woman with alcohol as her drug of choice, but there is a lot of education that I think is landing with women of childbearing age, and I do not treat as much alcohol use disorder as I have seen in the past. It's primarily opiate use disorder and methamphetamines.
Thank you so much. That is very insightful.
And did I answer the whole question?
Yes, you did. Thank you so much.
Okay. All right.
It sounds like we've definitely got some work to do, and I'm hoping that these panelists on here can help the community provide more insight on these challenges, and we can talk about how we can best work together. Thank you so much.
And this will segue, and there will be a lot of discussion about how medication-assisted treatment is the standard and has best outcomes for substance using pregnant women and the babies. So
yes, absolutely.
We'll get into that.
All right, our next question is for Heather. Heather, what are some of the most prevalent drugs being used in pregnancy that result in removals?
So, hi everyone. First, I want to say hi and thank you for letting me be a part of this panel. I'm super excited about it. So as Samara had mentioned earlier, I am actually employed with the Child Protective Division and I'm working as an investigator. So for this panel, I actually pulled some statistics of all of the removals that we've done so far with substance exposed newborn. And by far and large for this year, the most prevalent drugs that we are seeing infants test positive for or children being exposed to are amphetamines, which the parents admit to exposing their child to methamphetamine prenatally, and then cocaine. So when we look at the actual percentage of those removals, it was a whopping 57% of them are testing positive for the amphetamines, and then we had 35% that were testing positive for that cocaine. Like Dr. Fields was mentioning earlier, we're seeing an uptick in the amount of fentanyl cases that we're having and the amount of children that are being born exposed to fentanyl as well. So that's kind of a new trend that we're expecting for especially next year.
Thank you. Is Ellie on? I don't see her pinned.
Yes, I'm here.
Ellie is on. She's on by phone, and I think we reached our limit on pinning.
Okay. That's no problem. All right. Welcome, Ellie. This next question is for you. Ellie, have you seen a change in the frequency of babies born substance exposed at your facility over the last several years? If so, what do you attribute this trend to?
Hey, good morning, everyone. Sorry, I'm not able to get my camera to work, so I had to call in, but thank you for having me. I think in the hospital setting, we have seen a pretty steady substance exposed over the past couple of years. An increase in definitely the fentanyl. We have seen an increase in the alcohol use as well. That's in this setting is a little more new for us because generally we haven't seen that. The heroin has been more, and also the amphetamines. I think the biggest thing that we have seen is a breakdown in the family support system. A lot more girls that come in during their pregnancy or even here at delivery may not have any visitors at all. They may be here all by themselves, or family members aren't willing to help. So that has definitely been a big increase that we've seen in just the past 1 to 2 years. And definitely the homelessness and or staying with various friends. So that has definitely been an increase for us as well that we've seen.
That's definitely unfortunate that the women are coming in with no support. I know how difficult that must be for them. What sort of services do you guys provide for those women that come in? Are they different than ones that you would provide a mom who comes in with support? Sorry, this definitely was not on the questions. I just feel like someone else may be wondering like I am.
So when we have a gal that comes in during her pregnancy for a pregnancy-related issue, we try to get her connected to some type of residential program and or halfway house, sober living, shelter type setting. Sometimes we're successful. Sometimes they have to try and stay with someone until they're able to get into one of the places. Sometimes we get family members who are willing to take them for a few days until they're able to get into a residential program or a shelter. But the shelters have been full, I'm sure, as everybody knows, so that has been a problem as well. But one thing I want to mention, though, is we have girls that will come in wanting that help during their pregnancy, but when they actually have their baby, they become not homeless anymore. Then they have a place to live, and then they're stable. We often question is, do they really have a safe place to live? Or are they just saying that because they think, I have my baby now, I just want to be able to be discharged from the hospital with my baby. So that's always been a little bit of a concern for us as well. We do send them to get them connected to the home visiting program, Healthy Start PAP Plus or Healthy Families, one of those programs. And if it's earlier on in their pregnancy, we'll refer them to Nurse Family Partnership.
Awesome. Those are definitely some good connections for the clients and patients to have. I know how difficult it would be just, with your guys' role in the hospital, seeing the clients for only a few set of days, and really working your best to provide them all that you can within just a few days. And I could definitely see the concern with not having confirmation on whether mom really has a home, and maybe she's just saying that because that's the right thing to say in order to have your baby go home with you. So I definitely understand that concern. Thank you.
The other thing I was going to add really quick, if I can, was the other thing we have seen an increase in is the dual diagnosed, the untreated mental health. So we have seen a steady increase in recent years about women that are initially come to the hospital under a Baker Act, and they have untreated mental health and substance use. Some of them we try to work with, get them connected to services, discharged, and then they come back in again maybe 1, 2, 3 times Baker Acted. And sometimes when the doctors are concerned about their safety of themselves and their unborn child, they will keep them in the hospital through the courts, of course, until they deliver their baby. So we have seen an increase in that particular population. And that I could say, just for being in the hospital setting for several years, those women were far and few between. Now we probably have several every year.
Those are definitely difficult situations. Thank you for sharing that with us. Our next question is for Angela. Angela, what are the gaps in care / treatment / resources for mother and baby that may be contributing to the increase in the numbers of substance newborns that we're seeing?
So Ellie's response was a great one. Thank you so much to allow me to segue into mine. Starting with a quote from Johann Hari: "The opposite of addiction is not sobriety. The opposite of addiction is connection." So a little history: drugs were first banned in the United States about 100 years ago. And it was at that time that we started imposing punitive measurements on people that were suffering from addiction instead of helping them, because that is what we thought would deter them from using drugs. Obviously, we know different now. We stopped focusing at that time on drug use as a disease, but rather as a choice that deserved negative consequences. And because of that, there was and has been a fear among those who suffer from addiction that if they seek help from a formal resource like Baycare, or while in the hospital, or even from a family member or friend, or they admit that they're suffering, they're going to be judged and punished. So we as panelists and on this call right now, we all know that no community is immune to drug use, including ours. We've seen that in the statistics that Heather's read and the information that the prior panelists have provided. We all know that there are resources in this community not to only help expectant and new mothers, but to allow them to receive the care they need and keep their children in the home. Unfortunately, the community doesn't know these resources are available. And if they do, they're afraid that they're going to receive judgment or penalty in the form of a removal as a result of seeking help. Not knowing that a lot of these programs are trauma-based and connection-based, like my program, the Safe at Home Diversion Program. So aside from the addiction itself, I believe the fear of possibly losing their child to the system or being punished as a result of being pregnant and still using is one of the reasons why expectant or new mothers don't seek help. The lack of knowledge of available resources and fear of punishment could be, in my opinion, what's creating such a gap in the treatment and a rise in the number of substance exposed newborns.
That definitely makes sense. I think stigma definitely has to do a lot with that. Clients that I've worked with previously, they'll say, well, my friend had a baby and she asked for help and her baby was still removed from her care. So there's definitely fear coming from them, which is definitely something the community has to work on.
Absolutely.
Thank you.
Can I chime in? I have something to comment on.
Absolutely.
Angela, I really liked what you just shared. As a provider, there is a big window of opportunity for the pregnant substance using woman that does come in and wants help. And they are in my office and I have an evaluation with them. There's a window of opportunity to try to give comfort, let them know that treatment's available and that they're going to more likely have a healthier pregnancy and healthier baby as a result of engaging treatment. But always you got to instill in them hope that they can be substance free, go and have an infant at a hospital, and being on some of these medications with the support of an addiction treatment center and a staff at a facility like many of ours, they can keep that baby. It is the fear of the baby being removed if they're on methadone, if they are on Suboxone, some of these medications that put these women into remission and result in healthier pregnancies for the infant. Even if neonatal abstinence syndrome comes up, it's treatable and has no long-term negative effects on the infant. And so you have a lot to cover when this pregnant woman is in your office, but that it's a window of opportunity. So at any time that you have an encounter with a pregnant woman, substance using pregnant woman, you need to really take advantage of that opportunity to let them know of hope of being put into remission from their active substance use, having a healthier pregnancy, healthier infant, and having a very good chance of being that baby going home with them. If they have a DCF history, it can get very complicated. But overall, it's better if the woman is engaged in treatment. It is better. It's better for them. It's better for the pregnancy. It's better for the infant. So.
Absolutely.
Yes, I definitely agree. Thank you so much for that addition. And I'll also add to that, it's better if the person has a case plan also and is involved in treatment. Because I know a lot of clients just worry about how that will interfere with everything. And as we all know, we definitely encourage them to be involved in treatment, whether they have a case plan or whether they're newly pregnant or very close to delivery. I've worked with several clients also in the past who said, well, I'm 39 weeks at this point, the baby will just be removed and then I can try and get sober after. But there really is no timeline. So, at that small time that we get with those clients, it's definitely important to engage with them and provide them with information, education, and non-stigmatizing way. So thank you both for that contribution. All right, our next question is for Charlize. What education is provided by your agency to your employees regarding working with substance exposed newborns and their families?
Well, we work with a lot of partner agencies and contracted providers in addition to really provide the in-person services that our families receive. But once a child has been deemed unsafe and is working with either one of our in-home providers or our out-of-home case management agencies, all of those case managers are certified, and to become certified, they go through an 8-week pre-service intensive training cycle that has specific modules, one of those being substance abuse that also incorporates substance abuse and substance use during pregnancy, as well as some of the effects that can have on a substance exposed newborn. So in addition to that baseline training they receive to even be employed and kind of working with our families in the field, once they complete that process, they also receive ongoing in-service training that is really tailored to what their focus area may be. So we may have a case manager that really works more with kids 5 and under. And so our in-training curriculum for that case manager is going to focus more on those newborn needs, developmental needs, and could also include substance exposed pregnancy and substance exposed infants. In Pinellas and Pasco County, we also partner with USF for early childhood court. And so we have an entire court system that really wraps around these types of families involved with these concerns. And we also offer that specialized training to our staff that work in that early childhood court. And so it starts really from the beginning and getting involved in the field, and then is kind of ever evolving. Depending on the role that person may serve, and continuing that intensive in-service training to make sure that they are continually educated on the newest and up-to-date information as their career kind of unfolds.
Great. It sounds like you guys are definitely focused on providing copious amounts of training, which I'm always happy to hear. I know that there's always new things coming out, so it's important to stay on top of all that. So thank you for answering that. Our next question is for Jenna. What services do you provide to families who have substance exposed newborns, and what are some of the challenges that you as a provider face working with this population?
Morning, everyone. So like a lot of people have already said and touched on the fact that some of the challenges we have dealing with clients
I'm not sure if Jenna froze for anyone else, but she did freeze for me. Jenna, if you can hear us, we cannot hear you.
Oh, can you hear me now?
Yes.
How does the internet get funky the moment that I start to speak? Well, I said good morning, and I'm just going to repeat what I started. Sorry about that. So some of the challenges that we face with these particular clients with substance abuse issues is that there's usually a lot of mental health concerns. Typically, I would say with what we see, it's undiagnosed. Occasionally, you might see someone that's seen a doctor, but usually undiagnosed. Typically, there are housing concerns, sometimes homelessness, financial difficulties, employment difficulties, food insecurity, just not having access to things. So we provide tons and tons and tons of referrals to therapeutic services, food banks, although we do have some in-house food that we are able to give. We have a lot of people and there's only so much food, right? But we have lots of food banks that we work with, career services, housing assistance. Being that many of our participants lack support from their family or their friends, a lot of times based off of their past addiction issues, there's a lot of burned bridges. So our nurses and our home visitors, they'll assist them with applications for assistance, maybe helping them make a resume, because I would think everyone here would agree that with substance abuse, especially a long-term substance abuse, you find that sometimes people are lacking some pretty basic life skills that maybe they just didn't get because they were heavily into their addiction and they just never got that, whether they dropped out of school or didn't have family support or friend support, or never really worked a job. So we just sort of work to get them into those life skills, and also about bonding, attachment, protective factors for their children. And definitely pushing hard to get anything that is undiagnosed diagnosed, So then we can move forward and maybe we can get to the root of why there are substance abuse issues.
Absolutely. I think you make a great point when you say they're lacking some of those basic needs. I know, several people that I know who aren't involved with, working with this population. And, the main thing when I share about my experience working with patients, they'll say, well, I don't really understand. Why don't they just go and get treatment? It's there, they have funding for it. But what they're failing to realize is you don't just go and get treatment. You don't have a home, you don't have a job, you don't have money, you don't have food to feed yourself. So while yes, treatment may be, on that spectrum of things you need to get done, if you are not eating right now, if you don't have food and a safe place to sleep, treatment's really not going to be that number one thing that'll come after that. So thank you so much for that.
I agree. And I have to say, it's so nice to be in a Zoom room full of people that actually understand that, because the civilian doesn't always. So thank you.
Yes, absolutely. I definitely agree. All right. Our next question is for Michael. Michael, how does your agency address pregnant women who test positive for an illegal substance while engaged in your services? And what other service do you attempt to connect them to when this occurs?
Thanks. Good morning, everybody. Glad to be here. Sorry I showed up a little bit late. So that's a great question. And I used my phone a friend on a few ideas when I couldn't, I've been doing this for 13 years at Operation PAR and knew quite a few of these, but here's what I learned and I knew. So we, number one, increase the counseling frequency. That typically we need to know what's going on with a pregnant mom who's using substances. There is something obviously there. So we have evidence-based curriculum that is tailored specific to pregnant moms. So we want to make sure we're using that and we're not shaming them. We are just trying to find out which ways we can help. We schedule more random drug screens. We do that because we want to have that data on how things are going. We have group counseling that's available to them either in person or through Zoom. We are at the top of our list is making sure they have the education. So we're educating them on the health, the potential consequences of using substances while you're pregnant, at birth outcome. We have a release of information with their OBGYN. So we have that communication and we make sure that the coordination of care is alive and well. The doctor, program physician at each location can open up and fit in their schedule these individuals, these pregnant moms that are testing positive for. So while our program physician has typically a pretty busy schedule, ARNPs and our program physician make themselves available to pregnant moms that are struggling with substances. That these cases get discussed every week in our treatment team meeting. The counselor is well versed, and these more frequent sessions are giving them more information to present to the doctor and to everybody in the treatment team. And in that treatment team setting, we are not just presenting what we're seeing as counselors. We are getting all different information from the front office staff that checks the person in to the nursing staff that is at the dosing window. And I'm speaking my area is the methadone program. So a lot of these apply across our agency for moms that are testing positive, but in my scope to my focus in the agency is with the medication assisted treatment program. So let me see what else. So we provide, excuse me, we provide wraparound care for them so that we're not just, we encourage their partner, their significant other to be a participant in their treatment, that typically is extremely helpful, having that dynamic and not just working with the pregnant mom and inviting that. We have support groups specifically set up for pregnant moms, and we offer the father support too in these types of situations, and so that they have the skills to support the mom. So it's important that we do that. The other, what services or what other services do you attempt to connect them to? We have a village program, Operation PAR Village. I'm not sure if those of you who are familiar with that, but it's one of the only programs that exists like this in the state of Florida, where we have the moms and their children in treatment in a housing setting. And school bus comes around, and we have a daycare center where we work with mom and work with children, and pregnant moms are also there. And we put a priority on pregnant moms at Operation PAR. Any positive drug screen, any person that walks through the door that's pregnant, specifically too with opioid dependence, fentanyl issues, whatever, they get a priority. They will not leave our building without seeing a medical professional. So we have outpatient counseling programs that we refer them to. And we connect them to a lot of community support, Narcotics Anonymous, Alcoholics Anonymous, Zoom links to connect to those types of meetings if they can't get around, Smart Recovery, Celebrate Recovery, all different kinds of organizations, whether it be, community-based, church-based, whatever it is. And then we have lots of we have referral to them to a community-based in-home programs, and they help with prenatal care, nutrition, and stressors of being a new mom. That is what I had.
Thank you. I
Sure.
love that.
Hey, Missy, this is Ellie. Can I just pipe in there? I wanted to also mention from the hospital end, we will actually get moms that we want to get started onto one of the connected to Matt, and we'll coordinate directly with the methadone assisted treatment program with PAR and be able to have them leave our hospital straight to their door in the morning. So the times we've done that has gone extremely well. It's a good connection there. I just wanted to point that out. Huge help.
Oh, thank you so much. Missed that one. That's an important piece. Appreciate all that you do with that too.
Thanks.
Thank you, Michael and Ellie. I love to hear that you guys are also incorporating providing services to the father or support person as well. I know that is a big deal for a lot of our patients who are pregnant and substance using, is their partner sometimes is not on board with whatever they may have going on and with them being in treatment. So that is great to hear. Thank you. All right, our next question is for Cindy. Cindy, what is the experience of pregnant and postpartum women with substance misuse issues when interacting with OBs? How do they report being treated, and how do you feel like this can be addressed? We are not able to hear you. No, we can't hear you. We can see you talking and we can see you're unmuted, but unfortunately can't hear any sound. Okay, we can, if you'd like, we can come back to your question if you want to see. Okay, perfect. All right. So our next question is for Dr. Fields. What is your normal protocol for a pregnant mother engaged in medication-assisted treatment? Under what circumstances might this protocol change?
Yeah. So I've worked in both opiate treatment programs, and in the past I was at DACO for many years, and which is now the Cove, and like Michael Osborne, worked in an opiate treatment program, and with methadone primarily for the pregnant women with opioid use disorder. And currently, I'm outpatient. And I've been with Bay Care for about 3 years, and I work up here. And so how I meet substance using pregnant women is through when they come into our outpatient system. I'm at Adult Treatment Center here in Newport Richey, and we have a very large volume of patients coming through our various levels of care in outpatient, EOP, and IOP. And we can transfer over if needed to residential level of care. So protocols, well, first of all, education. Like I mentioned before, you want the women to keep coming back during their pregnancy and engage treatment. So I educate them that addiction is a disease, and I try to destigmatize right away, okay, and applaud them for coming in for help, and let them know that their disease of addiction is not a moral failing, and that they are on the right direction trying to engage services because they want a healthier pregnancy, and they want to get sober themselves and have a healthy pregnancy, and let them know that we can do that. And that so that's important from the get-go. I diagnose a substance use disorder. Single use is not necessarily a substance use disorder, but if they are diagnosed with an opiate use disorder, with a methamphetamine use disorder, what have you, I want to have them in an appropriate level of care. So education on medication-assisted treatment, whether it is methadone out of an opiate treatment program under federal and state regulations, or whether it is outpatient, I can prescribe Subutex or buprenorphine for pregnant women, and that is an outpatient medication option. As a waivered physician, I'm able to prescribe that Schedule III medication, buprenorphine, for pregnant women with FDA indication. And I tell them that what it does is, and if we're talking about opiate use disorder, it interrupts the craving process and prevents the withdrawal, which is not recommended in pregnant women. You don't want them to go through the 1 to 2 week withdrawal if they are abusing any type of opioid. It can be detrimental to the pregnancy. So education, get them started on Subutex in my setting, outpatient, and lock them into therapy. Get them assigned to a primary therapist for individual, group therapy, color code, and get them to try to engage fully all that the appropriate level of care offers, and see them often, especially initially, and monitor their urine drug screens, and see and educate them that, do they have an OBGYN? Have they engaged prenatal care yet? Like we said, a lot of these women are fearful and may not have been to the OBGYN yet, and we let them know that's okay, and recommend that now that you're in treatment, we want to coordinate care. So coordinating care with their OBGYN is very important. And I get releases so that we can speak to them, they can speak to us, and work, as a team with these women to get them into remission from opiate use disorder and usually other substance use, right? So the that's pretty much the protocol. And from day one, educate them that treatment decreases negative outcomes in pregnancy, brings them in tune with non-using substance pregnant women in terms of negative bad outcomes with a pregnancy. Plenty of non-substance using pregnant women have things happen during the pregnancy, but substance using pregnant women, it's exponentially higher to have preterm delivery, low birth weight. The mother can't bond with the baby, so there's issues there. All the way through the pregnancy, through labor and delivery and postpartum, it brings them in tune with decreasing negative outcomes to those of non-substance using pregnant women, and that's good for them to hear. And we want them to stay on medication-assisted treatment throughout the pregnancy, labor and delivery, and postpartum, so that they can stay in remission. So I educate them that just like if they had diabetes and got on insulin, they would stay on the medication, right? We don't talk about coming off of the medication. So these medications, methadone, Subutex, for opiate use disorder, it's important that they stay on these medications. Of course, we get the question, I would like to taper off so that my baby does not have, once I'm stabilized, taper off so that my baby doesn't have neonatal abstinence syndrome or withdrawal postpartum. But unfortunately, that results in a lot of relapse and disengagement from treatment. And so healthy mom, healthy baby, and we try to get them committed to stay on these medications through the whole process. And when hiccups occur, when there's issues, when there's disengagement, we go after them and we try to get them back in, right? And if there's a relapse, that's not a failure of treatment. That's a reset. What are we missing here? Are we treating your co-occurring mental health, right? Because there's a lot of that. There's co-occurring mental health, and we address that also, and that's very important. What's your environment like? Is it supportive for you staying sober? Do we need to try to find you safe housing? Are you safe in general? You know, do you have a partner helping you out? Some of the things we've already talked about. If they're not able to get into remission from active opiate or substance use, you know, what we regroup and what are we missing here, and try to go after that.
Awesome. Thank you so much. I love so many points that you made. And I think a side question that I would maybe have that would be beneficial for those who maybe aren't panelists and just are working with these patients in other settings. If you could just touch on, let's say, a scenario where you have a patient where you're recommending MAT to them and they're pregnant and they have heard stories or their friends have had experiences about, you know, well, I was on a certain milligram and with my last pregnancy and the baby went through withdrawal. So this time I don't want that, or I want to stay on a low dose. Or, you know, my friend went through that same thing and her baby was removed because of XYZ. I know you've been through a lot of those scenarios. So if you could just shed light on that very quickly to some of our attendees here.
You bet. So neonatal abstinence syndrome, therein lies the challenge, right? That is what is a big topic of discussion. So I actually view, and I hope you don't find it controversial, I view neonatal abstinence syndrome a consequence of successful treatment sometimes. That is, do we want NAS? No, we don't, right? We don't want that infant to go through that process. But we have to prioritize what the goals are. And to be in remission from active substance use, what we know and what I educate women about is the fact that when you add on medications, be it methadone, be it buprenorphine, to treatment as usual for substance use disorder, right? Which is the therapy, the support system, the addressing co-occurring mental health. When you add in medications, you have an exponentially better abstinence rate and prolongs abstinence rate from substances and decreased morbidity and mortality. It's throughout the literature, it's evidence-based, it's supported both anecdotally and in the scientific community in addiction treatment. So we know that, and so I have to tell them that, you know, we have to, getting on these medications, and if you're in remission, you need to stay on these medications. That's paramount. So I educate them again from day one about the possibility of, once the baby's born, the infant may have neonatal abstinence syndrome. So I ask, having regular prenatal care helps decrease the likelihood of NAS and staying in treatment, because if they get on buprenorphine or methadone, they are, and abstaining from other substances, if they're not using methamphetamine, if we can get them to quit smoking, that decreases NAS. So try to get them off all other substances is to their advantage. Making sure that they are in a center where it can be expected and that is welcoming to pregnant women on MAT. There are hospitals going to need neonatal NICU services and neonatal intensive care unit services, where the baby can be monitored, have them with the expectation that the infant is going to be monitored for probably 3 to 5 days. 5 days postpartum is protocol for most birthing centers, so that they can observe the baby and know that they're not going to have this delayed onset of symptoms. Neonatal abstinence syndrome, poor feeding, irritability, tremulousness, a myriad of symptoms that is withdrawal from the infant because they are no longer being exposed prenatally to methadone and or buprenorphine, and hopefully not other illegal substances. So it does happen, and there's the Finnegan scoring system. And if they continue to score too high for too long, they'll treat the baby. And I drive home the point that treatment may be necessary, but evidence-based literature shows no negative long-term outcomes from NAS. It's recognized, treated, and the baby may have to stay for a while on the medication of choice for that birthing center, whatever that medication is to relieve neonatal abstinence syndrome. I let them know that the birthing center is going to, the hospital is going to want to do conservative measures first: skin to skin, breastfeeding, swaddling, comfort care that may control the NAS symptoms so that they don't have to use medication. But if they do, they need to know that no negative long-term outcomes, and that once they're through the NAS, they're discharged home to them, and will be well. Okay, and also that they can breastfeed these babies, whether they're on methadone or buprenorphine. It is safe to breastfeed your infant postpartum, and that's important for many women. And breast milk is best, and it's appropriate and recommended by the American Academy of Pediatrics to breastfeed women who are born to moms on MAT. So, all those things said, you do hear of bad NAS, and it can be unpredictable. And the dose of methadone and buprenorphine doesn't always equate to the severity of NAS. And I let them know that, that it's unpredictable, but your chances of severe NAS are less if you don't use other substances, you're engaged in treatment, you go to a birthing center, you're prepared, you're educated. So.
Awesome, thank you. And I think, Michael, you had something you wanted to add to that?
Yeah, just Operation PAR used to transport its pregnant women to the NICU prior to delivery. We found that extremely helpful. I want to reintroduce that to those at Operation PAR, because the NICU nurses did education, swaddling, showed them, the light sensitivity, just gave them a lot of information on how to best care for the baby when they're at home. Just gave them a lot of information, gave them diapers. There was just a really good collaboration between NICU nurses and pregnant women on MAT. And I'm going to look back into doing that because I thought that was a really helpful process.
It's a great idea, Michael. And at the Cove, DACO, we used to do that too. And also we would have for women in residential treatment or in our outpatient programs, when I was at DACO, we would have moms who have had infants that had neonatal abstinence syndrome come back and talk to the pregnant women on MAT. And we found that very valuable.
Absolutely. I can definitely agree with that. I think hearing from other moms who've been in similar situation is always helpful. So thank you both for that. Cindy, would you like to test your sound again? No. No, we're not able to hear you. Okay, we can come back to you. I'll check in again. Thank you.
I was just going to let Cindy know that we can always have her dial in. I will put the number for her to dial into inside the chat.
Thank you. Our next question is for Ellie. Ellie, what education is provided to your staff relating substance misuse and medication assisted treatment?
Okay, so our yearly staff, the social workers on my team, as well as the nurses and the doctors, they do their yearly CEUs for their licensure for substance use, the mental health, domestic violence. There's like a series of them. A lot of the education is internally, often from our behavioral health unit. We have an education department. We also utilize our Healthy Start Parents as Teachers program, the Healthy PAT Plus program in the community that will come, and it's kind of cool as we set up about 5 to 6 sessions that the nursing team and our speech therapist, rehab, anybody who wants to join in on it throughout, usually over the course of 2 weeks and different hours, so we could hit the night shift, and they're able to kind of go over what they see in the community, what services are provided, what things that they find helpful from the nursing education piece in the hospital setting to what they do in the home setting. So we do that, coordinate that yearly as well. We also, probably some of you guys have already heard the Florida Perinatal Quality Review. We did the MORE initiative, which is the maternal opioid recovery effort. So with that implementation, all women that come into the hospital that have any type of opioid use, there's like a folder that we use for the doctors and the nurses and case managers, social workers. That kind of is a starting point to be able to get that mom engaged into MAT treatment and services in the community. And the key part is about having everybody participating in that. You have that doctor, midwife, who's that initial person who's going to be doing that exam, who may be finding her connected to what may be appropriate medically for her, as well as ordering any testings and labs, those types of things, as well as for follow-up care after discharge. And the nursing piece being able to help with that is for those patients that come in, maybe only here for a couple hours because they're here for a preterm problem or just wanting to get checked out. They're able to engage that mom into what things she can get help with once she gets discharged from the hospital. The social workers are not here 24/7, so that's the team effort part is connecting those moms to services on the outside. And in the MORE folder, it kind of has a breakdown of this is how you do it. And we partnered with the Healthy Start Coalition and created a mapping tool. And the mapping tool, we actually have one for all of Tampa Bay, for Pasco, Pinellas, and Hillsborough. We're able to give that directly to the mom to say to the patient, here it is, here's some places that you can go to, and here's some connections for you, which also includes all the treatment programs, the providers in the community, as well as the home visiting programs. When the social worker follows up with that, we make sure we get those added pieces connected for them. Think what else for the education piece. Those are like the key parts of the education, is really having the nursing staff, especially having the trauma-informed care, the motivational interviewing. They do a lot of the education piece just within the nursing spectrum, but they also do the SBIRT, the screening tool, and the 5 Ps. So those are good opportunities for the nurse to engage with that mom on what are things happening with you? Do you have any history of substance use? The series of questions, and that gives them the opportunity not just to identify the mom may have a problem, but also just we're here to help you, and then make those next steps for connections. And those are tools that the education piece is constantly having throughout the year, just in the hospital setting.
That's great. Thank you so much for sharing this. Is Cynthia, has she called in, or?
I have called in. Can you hear me?
Yes, we can hear you.
Okay, so I'll go ahead and answer. I hear an echo. Can you turn it off, the echo? Hold on one second. There was a,
No problem.
I have called in and I'm hearing an echo, so we're going to try to turn it off.
The echo might be coming from her computer too, if she mutes her, like.
Yes, okay, all right, now, okay, finally. I'm so sorry for that technical difficulty. I usually don't have that problem with this computer, so I apologize for that. So I'm going to go to that question that was asked of me about the treatment that some of our clients have experienced at OBGYN's offices. And I'm going to discuss what our care coordinators have said in East Pasco and what some of our care coordinators have said in West Pasco. And this is per client's report. This is not something that we've addressed with the providers or we've heard from the providers. This is what our clients are telling us. So in East Pasco, it's pretty much the staff are saying that the GYNs are supportive and they are providing resources and they are seeing the patients. In West Pasco, our staff, the majority of our staff are saying that they are receiving the OBGYNs are not refusing the prenatal care, the majority. But some are kind of ignoring the substance misuse and are not providing the resources per some clients' report. And some clients are stating that some providers threaten that the client's baby will be removed without help and without treatment. So we are getting some negative comments from some of our clients, especially in West Pasco. And in West Pasco, some clients, particularly those ones that are self-referrals or community referrals that do not have prenatal care yet, are stating that some providers in West Pasco are refusing services when they disclose that they misuse substances. We do get a lot of positive feedback from many about many providers in West Pasco too, especially there are 3 providers that a lot of our staff discuss that are very courteous and respectful to the clients, and they do support them, and they do provide resource information. One of my staff has actually gone to some of the appointments with some of her substance misusing clients, and she states that, these providers do have very good bedside manners, and they really do provide the support in a non-judgmental way. So for the ones that have had negative experiences, one of the parts of this questions was, how can we address this with the providers? And so I put a few ideas down, and it's mainly, I know providers are very intelligent, our clinicians are, they've got a lot of education, but maybe extra information and education is needed. And one is that we need to educate some of our providers to take a non-judgmental, flexible, respectful, honest approach when relating to patients who misuse substances. This can help build a rapport, it can help build trust, it can encourage the patients to continue to participate in prenatal care, because if they consistently feel judged, they're not going to want to go. They're going to want to skip it. So, and they may not listen as well, as if they're being respected and supported and guided, we might have more successful outcomes. Our SEN committee, I know, have provided resource information to our medical providers, and we just need to continue to do that. We need to, and it has to be up to date so that the providers know where to send their prenatal patients for services. So that is critical, and we need to just really promote that with the providers. Please refer your clients. Don't ignore this issue, because they're seeing these patients over and over again, and they can make such a positive impact on their health, their baby's health, and their well-being. We may have some successful outcomes, and they're set up for positive interventions if they will refer, if they will provide the information to the clients. I also think, I don't know what medical providers are doing this, but I think it's really important to screen for depression with our prenatal moms and our postpartum moms, because as many of you all discussed, mental health issues are often in conjunction with the substance misuse issues. They're co-occurring. So they can get them referred to the licensed mental health counseling or psychiatric care, et cetera, if they're screened for depression at the provider's offices. And of course, we want all of our providers to refer to Operation PAR for those clients who misuse opiates. We want to encourage all of our OBGYNs to serve, any substance misusing prenatal participant. It's critical that they receive for the health of this mom and the health of that baby, and they may be able to make such a positive impact in their life and in their health. So that's some of the ideas that, that I have that we can maybe do to offset any negative treatment by our OBGYNs in the community. So,
Thank you. Thank you for sharing that and, the experiences that your patients have gone through. I think it's definitely important for the OBGYNs to be a part of conversations like this, just so they can kind of see all different aspects of how we work with these substance using moms and their newborns and their families, so they can kind of see a different perspective of things. So there's definitely a lot of work to be done with that, and I agree with all of your ideas that you had. Thank you so much for sharing those.
A couple of quick points is just that Operation PAR provides medication-assisted training, education to any community organization. All they have to do is they can contact Operation PAR. We'll make sure we get them scheduled if anybody wants to attend. And as far as the finding of methadone-friendly doctors, OBGYNs, we have our clients share with counselors those that gave them that non-judgmental care, and we don't refer. We collect that list, and we don't say to a pregnant mom that this is who you should see. We just say this is a list created by clients for clients if you want to consider using one of these.
Thank you for that addition. Our next question is for Shalise. Should providers make a call to the Florida Abuse Hotline for substance exposed newborns whose mothers are engaged in medication assisted treatment? What information should be provided to the pregnant woman participating in MAT about what to expect regarding a potential call to the hotline?
It's a great question. While many of you are probably aware, everyone in the state of Florida is a mandated reporter. So I want to preface what I'm going to say. If there's ever a concern for a child's safety, then absolutely a call should be made to the hotline. However, with families already engaged in treatment, I think it really is an internal assessment on a case-by-case basis on whether it really warrants a call. If a parent's taking the appropriate steps and seeking the appropriate supports, I'm not sure that we would necessarily deem that child in an immediate at-risk situation. So the best guidance I can give is really, I think every provider needs to really look at the parent in the case, probably with leadership maybe, kind of its totality to really assess what's making us question if a report is needed. Is the child going to be unsafe, or do we feel like the parents made appropriate steps to ensure the care for their youth upon birth? In addition, also really looking at what do we hope to get out of making a report? If the family's already engaged in all the services that we can offer, making an abuse report may be a fruitless action because you're going to refer them to us to refer them right back to you. So I think it really is assessing every case on an individual situation. Some families may really not need that extra level of protection, or you may have that situation where someone touched on, I'm 39 weeks, I'm going to give birth in a week anyways. I'll worry about getting clean and sober after the baby's born. That might be a different situation as opposed to a mother who's been seeking appropriate treatment and support halfway through her pregnancy. So I think every situation is going to require kind of an individual assessment. Our goal is to not get involved whenever possible. We want to keep children safe. But there's so many providers, even just on this call, that can wrap around families that we don't necessarily need that family to penetrate the system if they are proactive in seeking those supports. I'm sure Heather can probably talk more about what to expect in the hotline. But like I said, if we can wrap around that family, that's always our number one goal. So if that call's made to the hotline, I think that parents should be made aware. So it's not a surprise, never appropriate, and kind of provide them that support and guidance on what to expect. First point being, if it is accepted by the hotline, that an investigator may come out, and they want to be open and honest with that investigator about sharing what is going on in their life, what supports or services they are engaged in, what additional items that they may need. And if they do get referred even further into the child welfare system, I think, like everyone has said, is we're not here to be judgmental. We are here to either wrap around you and support you as safely as we can in home. And if we can't, for whatever reason, our goal is to wrap around you, could still wrap around you and your child to get that child as home as quickly as possible and as safely as possible. Our whole team here is our whole goal is family reunifications, family stability. So at no point do we have judgment in regards to substance misuse. We understand that relapse is a part of recovery. And so that doesn't mean that we're not going to support you through those situations. And like I said, Heather can probably talk more about what to expect when that hotline call is received and what that looks like from the investigation standpoint.
I actually wanted to tack on to that too. So whenever we have parents that come in, mothers that come in where they have been engaged in services for a period of time and they're testing positive only for their prescribed medications, that's something that when that report comes to us, we're really trying to work hard with the hotline and getting it screened out. If there's no reason for us to be involved, that's just causing more stress on these individuals if they truly are being cooperative and already engaged in services. So when we can, we try to get that screened out. The hotline doesn't always do that for us, but that is something that we're trying to do before we actually go out and make contact with these families and then add a little bit of more stress on them whenever they're already going through so much with having a newborn in their home.
Thank you. Thank you both for sharing that. I think the other piece was more so what can providers share with families who have had a hotline report called in. So if, I had, let's say it was a social worker at a hospital and they called a report in, what sort of communication happens with the mom and how is she made aware of, what to expect? Because for some people, I know that can be quite a traumatic time, to have child protective investigators, show up to your hospital room or wherever the call has been made.
I'm going to let Heather answer that because our organization doesn't typically get involved until sometime after that initial contact. And so I'll let her speak to what that initial looks like.
So if you truly have concerns for the child's safety, we would ask that you do not have those conversations with the mom and you allow the CPI to have those conversations with the mom instead. The reason being is because a lot of the information that we have to gather, especially with our cases for substance misuse, we need it to be as real as it possibly can in that moment. So we don't want necessarily people to be able to prepare for our arrival and have things in place if, again, there truly is a concern that this child is going to be in danger in the care of these caregivers.
Thank you so much. Okay, our next question. Michael, what are your facility's standard policies and procedures for working with mothers of substance exposed newborns? And how do you prepare them for what they may face following delivery regarding a potential abuse registry call by the hospital?
I'm sorry, is this for me at Operation Power?
Yes.
Okay.
Do you need me to repeat?
Let's see how good I am off the cuff. I didn't get one more time on the question.
No problem. What are your facility's standard policies and procedures for working with mothers of substance exposed newborns? And how do you prepare them for what they may face following a potential abuse registry call by the hospital?
Can you come back to me on that?
Yes, absolutely.
Thank you.
All right. The next question is for Angela, what other services do you refer to when working with mothers who are misusing substances?
I think I shared this question with Jenna, but I would love to start.
I didn't, I don't see Jenna on my
I'm
screen.
here. I got kicked out. I'm sorry. I got kicked out and now I'm like, now I'm little again. Which is fine by me, but Angela, oh, now I'm big again.
Whichever
Angela,
you want to
you
answer.
go ahead. Yeah, we do share the question. You go ahead then.
Okay. So the question being, what other services do you refer to when working with mothers who are misusing substances? When a case comes to us from CPI, fortunately, Safe at Home has counselors in-house that provide a range of different treatment plans. And those treatment plans can include substance abuse recovery and support, substance abuse psychoeducation, and individual therapy. Our case managers are also certified to look for safety concerns and educate parents on those. For those families who would benefit from more community providers, we do refer to Healthy Start, Healthy Families, specifically for that CAPTA program, and for additional nurturing education or early childhood development. We refer outside providers for additional support that may be needed for their individualized plan. But we also do it to have more community eyes. And one of the things we don't do is medication management. So if medication management, like we've talked about, can be so crucial to the success of any recovering client's treatment, specifically those who have just given birth, we refer out for medication management, housing assistance, and basic physical resources. We also provide referrals for reduced or no cost early education or childcare through ELC, the Early Learning Coalition. And we make sure that we educate clients to any additional resources in the community that are available to them so that we can ensure that those wraparound services, those continuity of care services are present for them when their Safe at Home case has been successfully closed.
I would just echo a lot of what Angela said, honestly. One thing, because we do work a lot with Safe at Home when it comes to CAPTA, is that, you know, they do have Safe at Home and they are receiving those services from them because they have that in-house stuff. But then, like when she said, once, you know, they close out with Safe at Home, which is a great thing, you know, that means that they're making progress. They also sometimes have really gotten used to that and they need to still continue services somewhere else. So we refer out for that to treatment centers, therapeutic services, NAAA support groups. We hold parenting groups in-house. Just anything we can, like she said, to keep eyes sort of on, like the more services that we can, like everybody keeps saying, wrap around everybody, the better. So yeah, I would echo a lot of her answer.
Safe at Home is an intensive program. So on average, we may have a case, if it closes at the CPI, have a case for 60 days. For those cases that need that additional service, our in-home cases now can stay open anywhere between 9 and changing, I believe, into possibly 12 months. So we're there, we're intensive, we're there a little bit more long-term if needed, but Healthy Families, for example, or Baycare, any provider that can continue with that after we've gone away, we make sure that they're set up, you know, before we close them out.
Thank you, Will. And I am skipping around just a little bit for the panelists because there are a few questions that we have not touched on the topics at all. And I feel a lot of the individuals on this call would potentially benefit from hearing about them. So this one's again for Angela and Jenna. What is your normal procedure for a pregnant mother with a medical marijuana card who's using marijuana products?
Jenna, do you want me to go first?
That's fine. Go ahead.
So I would say of all of the questions that I have the pleasure of adding to, this one was challenging the most because with the medical marijuana, it is, I don't know if Heather would second me on this, in the child protection arena is still somewhat of a gray area. It's not advised that a mother be using marijuana while pregnant, but if it is part of her treatment plan and it is legal, that if she's received a medical marijuana card, we accept and respect that. In cases like those, if a medical marijuana card is present, education is paramount. Prenatal health care is a must, obviously. The mother may not be aware of the possible negative side effects of marijuana use during pregnancy, so the education is extremely important. However, if use continues, it's important that the mother's prenatal care provider be aware so that prenatal development can be appropriately monitored. And sometimes we'll further and state that it's important that the mother go back to the prescriber who wrote the medical marijuana card and inform them that she's pregnant.
I would again echo a lot of what Angela said. It is a bit of a gray area because, particularly as a nurse, you have to educate someone. I mean, yes, it's legal in some places if you carry this card, but it's never going to be healthy for a child that's in utero to be that happening. So what we do is if they have the card, obviously we can't really broach too much about that. They can continue use. They do have to notify their provider. We educate them on safety topics. We educate them on how it could affect the child. Education about purchasing from only reputable dispensaries, not off the street. And we also provide free lock boxes for them to lock that up and any other medication that they would need to keep out of sight of children.
Awesome. Thank you so much for that.
Can I add a few cents about that?
Yeah, absolutely.
Thanks. Yeah, I obviously as a provider, this is something that comes up. I want to emphasize that we are harm reduction. So when women come in pregnant and they are using fentanyl or heroin or other opioids or methamphetamine, the priority the goal is to be substance free, of course, but the priority is to stop the most harmful substance use, and that is opioids and alcohol and stimulant medications. We have a policy at Baycare. We have restricted medications, and medical cannabis is restricted. Yes, it's legal, but so are benzodiazepines and Xanax and oxycodone. So even though they're prescribed medications and legal, they're restricted when you're in a substance use program. And our goal is to be negative for all of those. So we drive that point home. Court systems are debating, but that's our policy. But we don't withdraw treatment if women continue to, use cannabis. I just wanted to make that point. So thank you.
Thank you for the addition to that. That definitely helps paint a better picture from your side of how you are treating patients as well.
And education is key, just like they were talking about, because cannabis during pregnancy does have negative effects, can affect neural migration, and a lot of development of the baby can be affected. So yeah, education is important.
Hey, it's Ellie. I was just going to pipe in because I get the question a lot about the medical marijuana and about abuse reporting. On the OB units, we do an online report. They're often when the patient has a medical marijuana card, they're generally not accepted. I do know the OB doctors, lactation, and the nurses educate the parents about marijuana use, especially if they're breastfeeding, and it is discouraged to not use even with the medical marijuana card while breastfeeding.
Thank you for adding.
And those that don't have a medical marijuana card but are verbalizing they plan to continue, we encourage them to go get a medical marijuana card and get it from the dispensary only.
All right, so I know it is a little bit past our time. I wanted to respect everyone's time. To those of you who have other prior commitments, thank you so much for joining us. We appreciate your input and everything. If those want to stay on, we're going to have Michael answer the question from earlier. And yeah, thank you all for joining us.
Thank you, everyone. I do have to go. They put a patient in at 11:40, so, and they're
Thank
here.
you. Thank you so
Thanks,
much.
everyone.
All right, Michael, you are free to go when
Okay, this will be very quick. Operation PAR doesn't have a specific policy and procedure for this, for working with mothers of substance exposed newborns. We would treat them the same we treat any patient client at Operation PAR. We know that CPI and DCF will get involved at the hospital if that happens. We kind of let that, do our part based on what their findings are. We treat the mother and not the child, and it's not that we don't care about the child, but we are treating the mom. We definitely continue treatment, as was said. The outcomes are exponentially, better for treating anybody rather than discharging them and having them go out to, if they're not ready, using, intravenously, whatever the statistics are. And our approach is keep people in treatment. At minimal, they're getting the benefit of meeting with a counselor and being on medication to help them. So we're not doing anything punitive, except that their eligibility for take-home doses will be affected if they're still testing positive. And we've opened, like I mentioned before, the doctor is definitely open to any of these meetings that the pregnant mom or after she's delivered postpartum may have.
Thank you, everyone, for joining. And I just want to thank you, Samara, for being on and being our moderator. And thank you to all of our panelists. We appreciate you, and we'll continue to do good work. And hopefully today we were able to identify some gaps that we can put towards our work goals in each of our different perspectives and sectors. Thank you guys for joining us. Sorry we did not get through all the questions, but we appreciate you all.